The following lecture is aimed for dental students, interns, junior trainees, junior residents of oral surgery and oral maxillofacial surgery, as well as junior residents of other dental specialties. I also dedicate this lecture to my fellow colleagues and dental practitioners of several dental specialties all over the world. May you all benefit from it. In memory of my late parents, may Almighty merciful God rest their souls in heaven and peace. Please allow me to give a brief bio about the speaker. My name is Mohammed Al-Shulkami. I'm a professor of oral and maxillofacial surgery at the Faculty of Dentistry, Suez Canal University in Ismailia, Egypt. This lovely city, which lies around 120 kilometers to the eastern of the capital, Cairo, in Egypt. It was named after the late great ruler of Egypt, Khedive Ismail, the one who did the opening ceremonies of the Suez Canal in 1869. I'm also the professor and the supervisor of the Oral and Maxillofacial Surgery Department at Faculty of Dentistry, Sinai University, Kantara campus in Ismailia. I also worked as a part-time associate professor at MIU University and MSA University for several years. I'm a visiting professor at the Faculty of Dentistry, Beirut Arab University, in the Oral and Maxillofacial Surgery Department in Beirut, Lebanon. I'm also the managing director of the Egyptian Dental Center, a multi-speciality discipline dental and maxillofacial center based in Cairo, Egypt. The main topic for today, I find it one of the most important topics in the dental practice, is the management of the medically compromised patients. And we continue our talk about the cardiovascular disorders in the dental practice. The previous lecture we discussed the first four disorders of the cardiovascular system, and we are going to start in this lecture with the cardiac arrhythmias or cardiac dysrhythmias number 5. So let's start with it. Talking about cardiac dysrhythmias or cardiac arrhythmias, we are going to discuss the pathophysiology, potential risks, and management. In simple words and in brief, the pathophysiology occurs when myocardial function happens and there is death or infarction of parts of the conducting system. So the patient needs to put what we call an artificial pacemaker, and bearing in mind that patient with artificial pacemaker is a myocardial infarction, a previous myocardial infarction patient, which means that we should treat him and manage him at the same protocol as myocardial infarction and angina and in general cardiovascular patients. However, we have some problems with the artificial pacemaker regarding our dental equipment. We are going to talk about the potential risks and the management afterwards. So let's take a look about a brief review of the literature. In the Journal of Conservative Dentistry, an article has been published in 2015 about interference of the apex locator, pulp tester, and diathermy on the pacemaker function. It has been concluded that the tested electronic apex locators did not interfere with the cardiac pacemaker. In addition to the electric pulp tester did not show any effect on the cardiac pacemaker. However, it has varying levels of background noise. But on the other hand, the use of diathermy interfered with the normal pacing function, leading to complete inhibition of the pacing system. Moreover, another article titled Safety of Electronic Apex Locators and Pulp Testers in Patients with Implanted Cardiac Pacemakers or Cardioverter Defibrillators. It was published in 2006 in the Journal of Endodontics. And it has been concluded that the 2 electronic apex locators tested and 1 electric pulp tester used in the study did not interfere with the function of any of the cardiac devices tested. And this study was done clinically on patients. So, what are the problems do we have in the cardiac arrhythmic patients? The patients are, of course, under anticoagulants, and we should guard against the postoperative bleeding during the surgery. And the most important topic is the electrical devices used in the dental practice. So, According to the literature, electrosurgery, electrocautery, and diathermy should be avoided. Cavitron, ultrasonic scanners should be avoided, and microwave-based devices should be kept away from the patient as well. And regarding the anticoagulants, please refer to the lecture of the hematological disorders and the anticoagulant section. But in brief, we can perform the clotting profile, especially the PTR and INR, and get a good understanding of the patient's status. Either we can consult the physician, can we stop the drug, or we can resume our procedures without stopping the drug and take the local hemostatic measures as usual. Coming to the CVA, or the cerebrovascular accident, we are going to talk about the pathophysiology, potential risks associated with such condition, and management protocol. There are two types actually of cerebrovascular accident or strokes. One is called the ischemic stroke, and the other is called the hemorrhagic stroke. In the ischemic stroke, the brain is deprived of the blood supply through a thrombus or imbalance which blocks the blood flow to certain part of the brain. On the other hand, a hemorrhagic stroke is characterized by severe or malignant rise in the blood pressure or hypertension, where the blood spills out from ruptured or break in the blood vessels in the brain, and there is area of bleeding in the brain which exerts pressure on certain parts of the brain and affects, of course, the brain function. The hemorrhagic stroke, as previously mentioned, the blood leaks into the brain tissues, exerting pressure, and there is, of course, disturbance of the blood supply as well. And on the other hand, in the ischemic stroke, the clot stops the blood supply to the area of the brain, leading to death and infarction in this area. Performing CT or MRI on the brain can easily detect the area of the hemorrhage or the area suffering from brain damage according to deprivation of the blood supply. Here it is pointed to by the white arrow. Another area is pointed here to by the white arrow. Usually the cerebrovascular accident patient, if he is lucky to survive the attack, will have some sort of disability, which may be hemiplegia, quadriplegia, loss of function like ability to swallow or speech or whatever, according to the area of the brain damaged. So they are considered of special needs, and you can bear this in mind while managing the patient. And if the office or the clinic is not equipped to receive patients with special needs or wheelchairs or whatsoever, you can resort to hospitalizing the patient and do your dental procedure on a hospital setting. And coming to the management protocol, consulting the physician about the patient status, and we defer the treatment for the first 6 months following the attack, and it is based, of course, like the myocardial infarction, on statistical evidence that there is a high risk of a re-attack within the first 6 months following the first attack, and after 6 months elapsed, you can have this risk to a minimum. And the patients, of course, are put on anticoagulants, especially if they are suffered the attack according to a thromboembolic event, and we can do our clotting profile tests, particularly the PT and INR, to have a good idea about the patient's status and whether he is eligible for dental surgery without stopping the drug, or with stopping the drug, or what can we do, or other we are going to resort to only local hemostatic measures, or what we can do about the case. Last but not the least, as I said, I would recommend that the patient should be taken care of under a hospital setting, and we of course consider the hypertension, because it is one or the other arm of cause of this attack. Consider the patient if he is hypertensive, put the guidelines of management of hypertensive patient, as I'm going to discuss later in this lecture. Coming to the hypertension, the classification of blood pressure for adults. The normal person is having the systolic blood pressure 120 or less, and the diastolic blood pressure 80 or less. A pre-hypertension stage where the systolic blood pressure lies between 120 to 139 and the diastolic lies between 80 and 89. While stage 1 hypertension is considered when the systolic blood pressure lies between 140 and 159, or the diastolic blood pressure lies between 90 and 99. While stage 2 hypertension, where the systolic blood pressure is over 160 and the diastolic blood pressure is over 100. What topics are we going to discuss in the hypertension? Types, consequences of hypertension, the dental implications, and last but not the least, the management protocol or management outline. What are the types of hypertension? Primary or essential or idiopathic hypertension, which actually comprises 95% of all cases of high blood pressure worldwide. Secondary hypertension, which accounts for only 5% of all cases of high blood pressure. And here the blood pressure is not coming by itself. It is secondary to another pre-existing medical condition. So the diagnosis is very important in such conditions. Last but not the least, a term which is used to indicate an acute severe increase in blood pressure, which is called hypertensive crisis. It is characterized by having a blood pressure of 180 millimeter mercury or more and a diastolic blood pressure of 120 millimeter mercury or more. And here I'm presenting some disorders associated with secondary hypertension, like acromegaly, chronic alcoholism, aldosteronism, which is characterized by hypernatremia, coarctation of the aorta, Cushing syndrome, which is increase in the corticosteroid secretion. Drug and herbal therapy are going to be discussed in the following slides. Hyperparathyroidism and hyperthyroidism and hypothyroidism are also causes of secondary hypertension. Obstructive uropathy and pheochromocytoma, which is a tumor or oversecretion of the suprarenal medulla. Of course, there is an intimate relationship between renal disorders and hypertension. Renal parenchymal disease, renal insufficiency, and renovascular disease, and last but not the least, sleep apnea. Let's have a brief idea about some drugs and herbs that might cause secondary hypertension. Acetaminophen or paracetamol while in long-term use, antidepressants, and unfortunately appetite suppressants for the people who would like to lose weight, cortisone, corticosteroids, dexamethasone and prednisone, of course, are among the drugs causing secondary hypertension, immunosuppressants like cyclosporin A and tacrolimus. We have been talking about cyclosporin A before in the renal and organ transplant patients. Please refer to this lecture. Monoamine oxidase inhibitors, and of course the top drugs we use in our practice, non-steroidal anti-inflammatory drugs, and unfortunately cyclooxygenase inhibitors too, like celecoxib. So please be aware when you use non-steroidal anti-inflammatory drugs with hypertensive patients. And as I mentioned before, we are operators. We should go and manage the pain and relieve the pain by doing operations, rather than resorting or relying on anti-inflammatory and painkillers. We can perform extractions, removal of a flap in pericoronitis, incision and drainage, or pulp chamber opening, and put a sedative in the pulp or pulp extirpation. We can rely on our hand skills to relieve pain rather than to rely on drugs. Sex steroids also used by people who are undergoing gymnastics and bodybuilding, and sympathomimetic amines and related stimulants like amphetamine and methylphenidate. What are the consequences of neglected or untreated hypertension? It can cause end organ damage, and the top sufferers of our body are the kidneys, the heart, and the brain. Later on, it can also lead to hypertrophy of the arterial muscle and other arteriosclerotic changes in the small arteries, which occur in response to high blood pressure and increase the activity of angiotensin II. And of course, this in turn will lead to impaired perfusion of the affected tissues. Last but not the least, development of ventricular hypertrophy and atherosclerosis of large arteries, which affects the blood flow to end organs. And if we can recall, that's what we said as an underlying cause of the development of angina pectoris in combination with other factors, of course. What are the implications of hypertension or the significance of hypertension for the dentist and the dental practitioners? According to the Joint National Committee for Hypertension, only 1/3 of individuals with hypertension have their blood pressure under control to the degree recommended by the committee. The dentist should take the blood pressure of all new patients regardless of their medical history and whatever they tell you they have their blood pressure under control or not. Current statistics indicate that 1 death will be prevented for every 11 patients the dentist identifies as hypertensive, and they can receive treatment sufficient to reduce their mean systolic blood pressure by about 12 mm mercury for 10 years. Furthermore, the dentist is believed to uncover untreated or inadequately treated hypertension in about 1 of every 5 adult patients tested by him. And coming to the measurement protocol of the hypertensive patient, what do we anticipate and what do we fear of? Orthostatic hypotension, as previously mentioned, those patients are taking antihypertensive drugs which lowers the blood pressure and leads to vasodilatation of the blood vessels, and this might lead to what we call postural hypotension. So don't change the position of the patient from supine to standing up or an upright position abruptly or quickly. You should let the patient sit in the upright position for a few minutes before standing up and leaving the office to avoid postural hypotension and fainting. Most of the commonly used antihypertensive drugs like centrally acting antihypertensives, diuretics, sympatholytics, and angiotensin converting enzyme inhibitors, or as we call them ACE inhibitors, and furthermore calcium channel blockers, all have been identified to cause xerostomia. There are oral complications that result from xerostomia like angerkylosis, altered taste sensation, candidiasis, dysphagia, glossodynia and glossopyrosis, and thirst sensation and increased caries index. There is a very important issue to the oral surgeon, which is gingival overgrowth, which is caused by calcium channel blocking drugs, especially nifedipine. Other miscellaneous reactions like lichenoid reactions caused by diuretics and ACE inhibitors. There is also burning sensation of the mouth, and loss of taste sensation can be caused by ACE inhibitors. And also ACE inhibitors and angiotensin II receptor blockers have been implicated in causing angioedema of the oral cavity. Regarding dental drug therapy, and on top of which comes the local anesthesia containing vasoconstrictor, we should follow the guidelines set by the American Heart Association and not to exceed the 0.04 milligram of epinephrine during the dental visit. And so we rely on the fact that low concentrations of epinephrine decrease the peripheral resistance by selectively stimulating the vasodilatory beta-2 adrenergic receptors rather than to stimulate the alpha constriction receptors. And because epinephrine is absorbed in the circulation, is quickly converted into inactive metabolites, so the injections themselves, if we use a couple of carpoles or 3 carpoles, they can be separated by about 30 minutes time to avoid cumulative effects of larger amounts of epinephrine in the blood. Postoperative bleeding is a problem that encountered in hypertensive patients with diastolic pressure of 110 mm mercury or above, and so it is not advisable to treat patients like this, and we should defer the treatment until further control and putting the patient under control, because postoperative bleeding is a problem and it will be persistent if the diastolic pressure is higher than 110 mm mercury. Some authors prefer not to let the diastolic pressure to be over 100, Others said that it's 110, so please be on the safe side always. Last but not the least, the interaction with hypertensive drugs with the drugs used in the dental practice. And this is a very important issue. And here is a presentation of the different dental drugs interacting with the antihypertensive drugs and the possible effect that this interaction might lead to, and the recommended action to be done. A quick look on the antihypertensive categories. We have the diuretics, beta adrenergic receptors, non-selective beta receptors, and ACE inhibitors like captopril, centrally acting alpha-2 adrenergic receptor agonists like clonidine, and peripheral adrenergic neuron blockers like guanethidine. And we are going to notice that the dental drugs having interaction with the antihypertensive drugs are mostly non-steroidal anti-inflammatory drugs, epinephrine and levonorepinephrine, and last but not the least, CNS depressants and opioid analgesics. And in all cases, as I said before, we should rely on our operatory skills rather than relying on non-steroidal anti-inflammatory drugs to relieve pain and rely on painkillers. But to be on the safe side, we can use such NSAIDs cautiously or resort to another painkiller or different analgesic like acetaminophen or paracetamol. Regarding the epinephrine and levonorepinephrine, the physician should be consultant, but however, we should limit the use according to the American Heart Association guidelines not to exceed 2 carpools containing 1 to 100,000 epinephrine during the visit, or even we can make it 1 carpool to be on the safe scale. Regarding the CNS depressants and opioid analgesics, they can increase CNS depression or their action can be potentiated while acting with the centrally acting alpha-2 adrenergic receptor agonists like clonidine, and we can use them cautiously. So there is no absolute contraindication of such dental drugs, but we can use them cautiously and we can follow the relative contraindication guidelines. And talking about ACE inhibitors as one of the most important antihypertensive categories, we need to understand the renin-angiotensin-aldosterone system and how it works. The liver produces an inactive enzyme called angiotensinogen, which needs to be converted to angiotensin 1 by the enzyme called renin. Renin is produced by the kidney as a result of decrease in the renal perfusion in the juxtaglomerular apparatus. And angiotensin 1 needs an enzyme which is called angiotensin converting enzyme, or the ACE enzyme, to be converted into angiotensin 2, which has some potential clinical effects, raising the blood pressure. The ACE enzyme is produced by the surface of pulmonary and renal endothelium. And once angiotensin 1 is converted to angiotensin 2, angiotensin 2 is going to exert some clinical effects like increased sympathetic activity and tubular sodium chloride reabsorption and potassium excretion, and increases water retention. It also stimulates the adrenal gland cortex to produce aldosterone, and aldosterone in turn is going to increase the sodium and water retention as well. Angiotensin, from its name, it exerts arterial vasoconstriction and increase in blood pressure. Last but not the least, it acts on the pituitary gland, posterior lobe of the pituitary gland, to produce antidiuretic hormone, and antidiuretic hormone is going to the collecting duct and leads to water absorption also. All these actions lead to water and salt retention, effective circulating volume increases, and perfusion of the juxtaglomerular apparatus increases. So this will finally lead to a negative feedback on the kidney and stop the production of the renin, to stop the cycle from its beginning activation of angiotensinogen to angiotensin 1. And to wrap it up, it is clear that angiotensin 2, by its clinical actions, will lead to increase and rise in the blood pressure. And using ACE inhibitors or the angiotensin converting enzyme inhibitors will lead to inactivation of angiotensin 2, and the blood vessels will enlarge and dilate, leading to drop in the blood pressure and giving a chance to the failing heart or a diseased heart to pump against less peripheral resistance. And in addition, the progression of a kidney disease due to hypertension or diabetes is also slowed. So let's go to the patient evaluation and measuring of the blood pressure. As we said, that the dentist should measure the blood pressure for every newcomer. But bear in mind that some patients suffer from what we call a white coat syndrome. That's to say that whenever you measure their blood pressure in a medical or dental facility, there is always be a rise in the blood pressure. They are going to record high blood pressure. So to keep a log of blood pressure should be taken during the course of daily life, or maybe at home. They send them at home service to measure the blood pressure. Stress reduction protocol should be implemented completely, and please bear in mind that if you are going to use sedation or give the patient sedative before coming to the office and tell him to miss his morning meal and fast, please, he should be told specifically to take his antihypertensive drug as normally scheduled. This is what the white coat syndrome patients look at our profession. When we wear the white coat, we are like monsters to them. So please try to implement the stress reduction protocol as much as you can, and try to cure such patients by giving them some sort of comfort zone treatment while being at your dental office. So after blood pressure recording and making sure that it is within the normal range and within the acceptable range for our dental procedure, we can carry out our procedure. But bear in mind always that the patient needs time or needs the chance for time out. So give the patient time out to go to the restroom because they are receiving diuretics, for example, or sometimes they need to take a fresh breath or a relief from the dental procedure. So please don't go for lengthy procedures at one time. And please remember to give the patient some time to relax. Regarding the post-operative bleeding and emergency management, as I previously mentioned, post-operative bleeding is going to be encountered when you have a diastolic blood pressure 110 millimeter mercury or more, and in such cases we can defer the dental treatment until having the blood pressure under control. But in case that you need to go for emergency management and the patient has an uncontrolled hypertensive case, or the diastolic is 110 or more, you can resort to consult the medical physician, and then you can go to put the patient in a hospital setting to have him under control and take a pre-medication to lower the blood pressure, and then you can go to perform your surgery. And always remember that in order for a hypertensive crisis to occur as a result of invasive dental procedures or dental surgery, this only can happen with the stage 2 hypertension cases, where we have a high systolic and high diastolic blood pressure. So please bear in mind to put the patient under control before you go to your surgery, or otherwise put the patient in a hospital setting. This is how you can record the blood pressure using the regular sphygmomanometer or the wrist digital blood pressure recording, which is put on the wrist of the patient. Wrap it up. Cardiovascular disorders, as we said, are one of the most common causes of premature death or death worldwide. And as we said, the number of cardiovascular diseases has risen from about 271 million in 1990 to about 523 million in 2019. And in the US in 2018, there has been 30 million persons recorded of having cardiovascular disorders, and in Egypt about 46% of mortality rates in 2017 was attributed to cardiovascular disorders. And as we said before, be aware of the causes: smoking, diabetes mellitus, hypertension, obesity, laziness and lack of exercise, unhealthy and junk food, over anxiety and over exhaustion, and excessive nervousness. Please take it easy on yourself and try to lead a good style of living and a healthy style of living. Remember always that this is the condition of your heart under hypertension. Hypertension does to your heart like this figure, and so that's why it's called the silent killer. Hypertension is referred to as the silent killer because it is, as we said, it is the playmaker of all the cardiovascular disorders, or the key player in the cardiovascular disorders. And please remember to take it easy on yourself. We all love food and we all love to eat delicious food, but please take it easy on yourself. In order to do well what you are saying, you have to see well what you are doing. This is one of my most favorite quotes, and I would urge you that when you're dealing with a hypertensive case, please try to put the systolic and diastolic blood pressure under control, and don't work for a patient who has diastolic pressure more than 100 or 110 according to some different authors. But please, when you have excessive bleeding for a hypertensive case, think of the systemic cause rather than the local cause. And of course, if this patient is a previously cardiovascular patient, he might be taking also anticoagulants, so be aware of the anticoagulant and the INR and the PT. Have them in your office to know the status of the patient, whether he's eligible for surgery or not. Because if you have a profuse bleeding, you are going to deprive yourself from seeing well what you are doing. Last but not the least, we are going to the endocarditis risk patients. In the past 25 years, the American Heart Association recommended that patients are at increased risk for endocarditis, and such patients that who have had a previous endocarditis, or they have had congenital anomalies in their heart valves, or the patients who have had previous rheumatic fever. And such patients, they should receive prophylactic antibiotics before certain dental, gastrointestinal, and genitourinary procedures. But the American Heart Association also had done with the national and international experts on endocarditis, they had done extensively review on the published studies during the past 25 years to ensure or determine whether such procedures need prophylactic antibiotics or not, or are actually causes of endocarditis or not. In the 90s, we used to give ampicillin and garamycin to the patients 1 hour before the procedure, and we continue the ampicillin for 48 hours post-operatively. But nowadays, the experts concluded that there is no conclusive evidence linking the dental, gastrointestinal, or genitourinary tract procedures with the development of endocarditis. They also concluded that endocarditis is much more likely to result from frequent exposure to random bacteremias associated with daily activities rather than such surgical or interventional procedures in the dental, gastrointestinal, or genitourinary tract. Moreover, they added that the risk of antibiotic-associated adverse effects exceeds the benefit, if any, from prophylactic antibiotic therapy. And they added that the maintenance of optimal oral health and oral hygiene in patients having pockets and bleeding gums might reduce the incidence of bacteremia from daily activities, and it is more important than prescribing prophylactic antibiotics for dental procedures. Here we can see that the healthy valve above, and on the below figure, there's some collection of bacteria called vegetations. They colonize on the defective valve. Most probably this is caused by Streptococcus viridans and Staphylococcus aureus. When they enter the blood after dental extraction or bleeding dental procedure, they can cause a problem, endocarditis in the defected valve. And here we can find the tricuspid valve between the right atrium and the left and the right ventricle, and the mitral valve between the left ventricle and the left atrium, and the aortic valve as well. They all, if they are defected, they might be colonized by vegetations. In this figure, you can see what we call the regurging or the mitral valve regurg or mitral valve leakage, while the blood is being pumped into a narrowed or a stenotic aortic valve. So, the American Heart Association has categorized the patients into high risk and moderate risk and low risk categories. So, the high risk and the moderate risk, they should receive prophylactic antibiotics before the dental treatment. Like the ones who are having prosthetic cardiac valves, or the ones who have had a previous infectious endocarditis, patients with complex cyanotic congenital heart disease, cardiac transplantation recipients who develop cardiac valve abnormalities afterwards. While the moderate risk category who should also receive prophylactic antibiotics are most other congenital malformations of the heart, acquired valvular dysfunction like the rheumatic heart fever patient, hypertrophic cardiomyopathy, mitral valve prolapse with valvular regurgitation. Whereas the negligible risk category where prophylactic antibiotics are not recommended include mitral valve prolapse but without regurgitation, coronary artery bypass graft, as we previously mentioned, they don't need prophylactic antibiotics, physiological function or innocent heart murmurs, isolated secundum atrial septal defect, surgical repair of atrial septal defect and patent ductus arteriosus, and any congenital defect that had been surgically repaired does not need prophylactic antibiotics anymore. Previous rheumatic fever without valvular dysfunction. The patient was lucky to survive the previous rheumatic fever without any valvular damage. Furthermore, the oral procedures and dental and surgical procedures have been also categorized to procedures that need prophylactic antibiotics, or the prophylaxis is recommended, and other procedures that do not need prophylactic antibiotics. Let's see first the oral procedures where prophylaxis is recommended. Dental extractions and biopsies, periodontal procedures, periodontal surgeries, dental implant placement, periapical endodontic surgery and procedures, intraligamentary local anesthetic injections, dental prophylaxis or dental scaling and root planning when bleeding is expected. Any other procedure that might anticipate or cause intraoral bleeding should be treated like the same and giving prophylactic antibiotics before procedure. On the other hand, the oral procedures in which prophylactic antibiotic is not recommended. They include routine local anesthetic injection, whether infiltration or nerve block, intracanal endodontic therapy, routine endodontic therapy, and routine restorative dentistry, suture removal after surgeries, and last but not the least, taking impressions for prosthodontic or orthodontic purposes. And the regime of antibiotic recommended by the American Heart Association is as follows. First, the standard prophylaxis is to give amoxicillin to the patient. The adults should take 2 grams orally 1 hour before the procedure, and the children should receive 50 milligram per kilogram body weight orally 1 hour before the procedure. In case that the patient is penicillin allergic, he should receive clindamycin. The adults should receive 600 milligram of clindamycin 1 hour before the procedure orally, or children take 20 milligram per kilogram body weight. Patient also can take azithromycin or clarithromycin. The adults can receive 500 milligram orally 1 hour before the procedure, and the children take 15 milligram per kilogram body weight orally 1 hour preoperatively. Clarithromycin, the adults can receive likewise 500 milligram orally, and the children can take 500 milligram per kilogram body weight. What if the patient is unable to take oral medication? There are several reasons which can lead to, or you can tell the patient that you are coming for sedation or for a GA, and you can be a fasting. So you are going to take ampicillin injection 2 gram intramuscular or intravenous 30 minutes before the operation, and the children will take 20 milligram per kilogram body weight IV 30 minutes before the procedure. In case that the patient is unable to take oral medication and is penicillin allergic, he is going to receive clindamycin 600 milligram for the adults IV 30 minutes before the operation, or cefazolin. Adult will take 1 gram IM or IV 30 minutes before the procedure, and for the clindamycin, the children will take 20 milligram per kilogram body weight 30 minutes before the procedure intravenously, and the children will take cefazolin 25 milligram per kilogram body weight intramuscularly or intravenously 30 minutes before the procedure. And so this will only be the regime needed. It's only to be taken one injection or one shooting dose before the procedure, and no other doses is going to be needed before the procedures. Because before the year 2000, we used to give a shooting dose or an activating dose of bactericidal antibiotic before the procedure, and we gave another one, half the dose, 6 hours after the procedure. But nowadays we only resort to one shooting dose, which is given before the procedure. And in all instances, remember that the total children's dose should not exceed the adult dose by any means. Albert Einstein once said that everyone is a genius, but if you judge a fish on its ability to climb a tree, it will live its whole life believing that it is stupid. So please explore your gifts and talents and skills and try to make the best use of them. Finally, I would like to thank you all for your kind attention. Thank you so much.